The skin. Why are, why are we studying these things? It's because there is a biological explanation about like a biological explanation about the connection between skin and mind. So first of all, what we have to know that the skin and the mind or the nervous system, they are from the same origin. So embryologically, after the fecundation, the skin and the mind, they are coming from the layer which called ectoderm. So when you try to examine this ectoderm, you will see those cells that we have in the nervous system, the one we have on the skin, they are belonging to this layer. And that's why you can see we have many conditions, skin conditions, which can have impact on the mental illness, on the nervous system. And we have also some nervous system problem which can impact on the skin, as we will see. This is the first explanation that is showing the biological connection between skin and the mind. The second one is the brain. We have what they call brain skin axis. So the central nervous system, the human system, and the skin communicate constantly through hormone, neurotransmitters, and the cytokine. This is sometimes called is what they call the brain skin axis. That means something which is happening in the brain, it can have influence on the skin. And what can explain it is the influence of hormone, the influence of neurotransmitters, and the influence in of cytokine. As we see, when we have inflammatory disease like eczema, psoriasis, what we have inflammatory um, uh, substance which like cytokine which play the role. When you have a mood condition, you have the neurotransmitters like dopamine, like serotonin, which play also the role. And you can see also when you have hormonal imbalance, sometimes it can have this condition. The third thing is what they call the stress response and hypothalamic pituitary axis. What is known is whenever someone is stressed, your body will, when you are stressed or you have an emotional imbalance, your body will produce a certain hormone, we call it cortisol. And when cortisol is produced, the production of cortisol can lead to increase the production of oil, it can lead to increase the production of cytokine, and can lead to the production of pro-inflammatory substance that can lead to many skin conditions. So when we reverse also in the other side, when you have inflammatory disease, it can also create like the feedback cause emotional imbalance. So this axis is one of the explanation about the biological connection between the skin and the mind. We have the neurotransmitters and neuropeptides in the skin. So on our skin, when you do some assessment on the skin, you have these substances they call neurotransmitters and neuropeptides. So the skin cell can produce it in response to neurotransmitters like serotonin and dopamine. And this chemical messenger will influence itching, pain, vasodilation, and inflammation. So when someone is stressed, the stress can cause a mood disorder, and the mood disorder can cause inflammation, and all these things can create like the vicious circle. We have also human system link. So psychological distress can derange the human system towards what they call the pro-inflammatory cytokine. So we have the IL-1 up to TNF alpha. So many skin diseases like psoriasis, atopic dermatitis are inflammatory mental stress and can therefore amplify the disease activities. The microbiome and the barrier function. There is what they call gut-skin-mind axis. So our gut is containing some microbe. Those microbes They are in balance with the skin and the mind. When there is an imbalance of the gut microbiome, it can in one way cause inflammation, and this inflammation can trigger the condition like acne, like eczema, like psoriasis, or it can worsen it. In another way, the imbalance of the gut microbiome can also increase the production of certain neurotransmitters like serotonin and dopamine that can lead to many of the conditions like the mood condition like depression or mania or something like that. And the last explanation, biological explanation, is the feedback loop, what they call the feedback loop between skin and brain. So there is a visible, when someone has a visible skin change, it can increase emotional distress. And that distress can then cause a feedback to the hypothalamic pituitary axis. So in short, mind and skin are in bidirectional influence. So when someone has stress, anxiety, or depression, it can change hormone, immunity activity, and neurotransmitters that can aggravate the skin disease in one way. In another way, we can see how you have a skin problem, it can cause a mind problem. Like when you have a visible symptomatic disease, skin disease, it can increase the emotional distress, which will worsen the mental health. So both systems, from a biological integrated network, they can interchange. There is no a separate compartment. So all of them are working together and they can influence each other. So what are the common mental health conditions among a patient with skin condition? So this is very important to know for all of us as leaders. At least if we can be able to identify this common condition, it can help us to lead our patient. It can help us to detect the warning sign. It can help us to help our patient to benefit from treatment in the early stage. So these are the common ones. The first one is depression. Depression is one of the most frequent psychiatric comorbidity in dermatology. And people with chronic or visible skin condition, they often experience, so when someone has depression, what are the symptoms? That person will show low mood, loss of interest, guilty, hopelessness. And they say the prevalence of depression among persons having skin condition is 2 to 3 times higher than the general population. And this is very important to know because suicidal risk is elevated. Very, very important to know and very important to detect this sign as early as possible so we can prevent the suicidal risk. I know, Peter, if you remember, for person living with albinism, I think some year back, we have lost, I can say, 5 of them in different countries. And the leading cause was depression. And it's very important for us to do that. The second condition is anxiety disorder. And anxiety disorder is a group of conditions. And it has many conditions in that group. And the most prevalent one are the generalized anxiety, social anxiety, and panic attack. And those are the commonest anxiety disorder that we can find in person living with skin condition. And the general anxiety is constant. So when someone has a general anxiety, it manifests by a constant worry about his appearance, is worried about the disease progression, is worried about the treatment cost. And another condition among the anxiety code is what they call social anxiety. Imagine when someone has something like a condition like vitiligo, for example, or albinism, those disfigurating condition. Sometimes they fear to appear in the community. So some of them, they can avoid even to attend meeting. Some of them, they can even refuse to go to school. So it is very common. We have panic attack. Some patients may develop a sudden intense of fear linked to social or medical stressors. The third condition is what they call body dysmorphic disorder, BDD, is manifested by the person being very preoccupied with a perceived defect in appearance that others see as minor or unnoticeable. So this person, he can have something small, like other people around, they are not even, they are considered as minor, but for him, he make it to be something serious for him. And is common in severe acne, when someone has a scar, when people have low hair loss or pigmentary disorder, and may lead to excessive minor checking, grooming, or repeated cosmetic procedure. And this one is more common in dermatological clinic than in the general population. The fourth one is stress-related condition. So a person with this condition can present with chronic stress and adjustment disorder. The stress may worsen the skin condition. As I say, when someone is stressed, he can release cortisol, and cortisol can cause inflammation. Inflammation can trigger psoriasis, eczema, and all these inflammatory disease. And they say up to 50% of patients report stress as a trigger or exacerbating factor for those conditions. And the person will show high rate of insomnia, irritability, and adjustment difficulty around when he is diagnosed. So this one is not a psychiatric condition, but is something like a psychological distress that people with skin conditions show. So they have low self-esteem and identity issues. And that can contribute to difficulty and impair the quality of life. Sleep disturbance also is common, and it can be caused by the itch, the pain, or emotional distress that can lead to insomnia or poor quality of life, which will worsen. Imagine if someone is not sleeping. When you don't sleep, the next day you will have a mood problem, and you can have problem with coping. The seventh condition is abstinence. This is how people now cope. It's a maladaptive way of coping that some people or patients with skin condition can present. So is that they will start using substance to cope with the shame, the pain, and the stress. And so that will not be very helpful for them. And the last one is suicidal ideation and behavior. So this increases the risk, especially in severe psoriasis, acne, chronic scarring condition. And early detection is very, very important. This one I want to take your attention to tell you, like whenever you see someone talking about having a suicidal behavior or ideation, please take it serious. Take it serious. And in most of the case for us as a psychiatrist, what we do, we assess the person and we take our time to score and to see if this patient can be admitted or not. So don't take easy anytime that you see a person talking about having a suicidal ideation on behavior and behavior. And the last one is what they call somatic symptom and related disorder. Here, some individual will develop excessive worry about bodily sensation or skin lesion, and that will cause their functional impairment. So, after understanding those 9 common mental conditions that we can see among our patients having skin condition, this is the way we can reduce the stigma among these patients. First of all, we have to organize public education and awareness campaign using the different media like TV, radio, so we can explain like most of the case like this condition are not contagious and often can be caused by bad behavior causes. So it's very important to educate people using the different media. And when we are educating, you have to use simple language. I'm fearing even me who is explaining here. I've tried as much as possible to make these people, this presentation to be somehow simple. But it's sometimes difficult because we have many technical words that cannot allow us maybe to understand. But in most of the case, when we are doing public education, use a simple language and give some local example and testimony from real patients. Don't be too much theoretical, but be more practical. And you highlight the fact that many skin are treatable or manageable. School and youth sensitization is very important to integrate lessons about common skin disease and albinism into school and health club or science classes. I can give an example of myself. I completed medical school when I didn't know anything about albinism. But is when they have chosen me to go do my master in dermatology. That's the time. So that I've tried to learn about this. So you can find in different medical school, they don't emphasize about skin condition, but as leaders, our way of reducing stigma is to integrate those lessons. So we have to make sure that they integrate this lesson. We train the teacher to respond appropriately when a child with skin condition is teased. Engaging community and faith leaders. This one, we have to engage the religious people, the traditional and local leader on the fact about skin disease and to encourage them to speak publicly against myth and discrimination, as we can see in many countries of Africa. When it comes to albinism, people are killed because of this maladaptive or poor knowledge about the condition, and people start thinking about like maybe they have some special power, what. So it's very important to engage these people, to train them so they can be able to understand the skin disease, how does it occur, how they can manage them, and they can talk publicly about that. The patient role model and storytelling. Always support patients with skin condition to share their success story in the media and community meeting or online. So, because seeing someone who is traveling with a visible skin condition normalize, it's a reduced fear. Peer support group. This is what we are doing with Global Skin. We have to create safe space where patients can meet, share experience, and build confidence. So this group can also lead outreach activity in market, school, or churches. Training health workers. I gave example of myself. It doesn't mean that if someone is a medical doctor or a nurse that he knows our condition, our skin condition, or this connection we are talking about here, my skin and mind. Most of our medical practitioners, they are not aware about that. So it is very important to train dermatology and primary care staff to speak respectfully, to explain the diagnosis clearly and address mental health aspects. To not be focused just on the skin, but to understand this connection and to treat a person not just by considering one side, but as an entire person by using the psychosocial aspect. So we train them to reduce stigma that can sometimes originate with health facility. This is very important. You go to a certain hospital, you can find maybe someone who has skin conditions, skin rashes. They don't allow him maybe to associate with other patients, thinking maybe that it can be can contaminate other people or not. So sometimes the stigma is also coming from us as health workers because of poor knowledge. So that is very important to train health workers. Don't put in your mind that any health worker is able to understand or he has a knowledge on skin, of our skin condition. Inclusive policy and advocacy, very important. We have to work with Ministry of Health, Gender and Social Affairs Ministry to develop policies that can protect people with visible differences from discrimination at work or school, to promote integration of mental health service within the dermatology clinic. We have also to help to increase the accessibility and the affordable care. Provide consistent dermatology treatment and counseling. When people see their condition improve, public attitude can change too. And to offer, especially those specific drugs or specific treatment like sunscreen or medication in unified, non-stigmatizing way. Positive media image. In most of the case, this is very important to know. In most of the case, when they use people having skin condition, I want to emphasize more about albinism. They give them a like whenever these people of media use them for maybe for movies or for doing some drama, in most of the case they always put them like victim. They always put them to play a negative role. But I think we have to encourage journalists, filmmakers, and advertisers to portray people with skin condition in a normal, positive role. Don't put them just in the film like poor people. We can put them like the hero, or someone who is doing like is the boss, or someone who is maybe the strongest, but not just putting them like victim. That is giving a very bad image on them. That is the way also they are talking about in most of the case in the film, the movie, they put black people like as victims. Black people. That was common in the past. But I think after people realizing it, now we can have now movies when we see people with black condition, like black color, are now maybe like hero. So this is the way we can also do to work to fight against stigma. And 10, the last one, I think this is we have to empower them and to help them to advocate for themselves. So we have to train patient leader in communication, right, and self-esteem, so they can confidently challenge discrimination and support others. When they know their rights, they know the rules, they know how their condition is, how they can understand, how they can ask for help for maybe to implicate the government to work on their need. So when themselves they fight for themselves, it is very important, because when you come, like you are the one who is experiencing the situation. You can explain it very well than someone who is not experiencing. So there is a need of empower our patient to help them to do what they call the self-advocacy. So the bottom line that we have to know for reducing stigma is that reducing stigma is not just by giving information, but it's about changing people's hearts, changing policies and practice at every level, while strengthening the confidence and visibility of those who are affected by this condition. So what us as a patient leaders, I think this communication, this meeting, this webinar is concerning us. The majority of us, we are patient leaders. We are what they call peer leaders. We are patient advocates. We are champions. So what is our role? Our role is to support our patient with empathy. So we have to listen and validate when they come to you. You have to talk to them. You have option to share the same life experience as other patients. You have to offer the level of understanding and empathy that maybe the health professional alone cannot provide. As I was saying, as a peer leader, you know the condition, you are experiencing the condition. So you can explain it more to your member or a member of your organization because yourself, you are experiencing it. And you can complement what the package that the doctor is giving. So we are very important. We are very important in this field. We are very important in this package that we are offering to our patients. The peer support of us as leader can reduce the isolation by organizing group discussion. So people cannot feel alone. They cannot feel like now experiencing the things alone, the condition alone. People have to, when they are meeting together, everyone can experience, can share his experience. Everyone can share the way he's coping with the condition. Everyone can share maybe the way he has normalized, and other people can learn from each other. Education empowerment by information sharing. Leader can disseminate clear evidence-based information about the link between skin condition and mental health. Here, I'm emphasizing about a clear evidence-based. So that means that you, as a leader, you have to have the knowledge. You have to have the knowledge. So when you have the knowledge, it can help you to share this information to other people. So that is very important for us to look for knowledge, very important for us to study, very important for us to know our condition so we can give something which is evidence-based, not just like whatever people can speak in the community. So that's why you can disseminate also bad information that can lead your patient maybe to get problems. Skill building, they can teach coping skill. This is very important. The coping skill is stress reduction, self-care routine, confidence building, and share practical tip for managing trigger or flare up. So the problem is time, but I think next time, if it can be possible, we can have time to discuss about this coping skill mechanism. It's very important. So everyone has this way of coping with the condition. So other people knows they know how to reduce the stress. Other people know what the routine self-care they are giving to themselves and which are successful, and they can share with other people. Navigating care, a leader can guide peer on how to access dermatological and mental health service, medication, or financial support. This is our role. If you as a leader, you are able maybe to access to some specific or special care, it doesn't mean that all your patients will be having it. So your role as a leader is to guide also your people. Your role as a leader is to make like in your community, those means has to be available. I can give an example. When we started these things of albinism in Congo, sunscreen was not available in Congo. So what we did, we made our effort to make sure that sunscreen can be available in Congo as a leader. And as I'm telling you now, person living with albinism in Congo, they are benefiting. I think this is what Peter has done in Ginger. Sunscreen is available. So this is very, very important. As a leader, you have to guide your peer to access to dermatological and mental health service. Very important to know. Advocacy and stigma reduction. So by doing community sensitization, Patient leader can speak at school, churches, workplace, and local media to challenge myths and stigma about skin condition. Very important to know, to go to school, to explain what is going on with skin condition, how people experience them, how you can get treatment or you can be managed for that. So very important. Policy engagement. They can represent patient voice in hospital community with Ministry of Health to improve integration of mental health into dermatology service. In most of the case, I think now sometimes they are starting to include the patient in the, I can say, hospital, different hospital community. But some time back they were not like that. So we have to emphasize about that. We as a leader, we have to be involved in the leading, like in the leadership of our health system in different level. So don't think that health system is for doctors, for nurses. No, you have the place, you have the role to play when you in this system. So it's very important for us to fight to get involved in this system. Early identification and referral. As I said here, of the explaining the different conditions which are common. So us as a leader, we have to be able to recognize warning signs because they are close to other patients. Leader may spot early sign of depression, anxiety, and suicidal thoughts. That can help to link that person directly to the healthcare. Then they can encourage timely referral to mental health professional and reduce the shame of seeking help. Building peer network, very important, by building support group, which will facilitate regular group meeting, face-to-face, online meeting, where patients are sharing experience, coping strategies, and encouragement. Mentorship program, very important, by pairing newly diagnosed patients with experienced one for guidance and reassurance. So, like I'm giving an example, like I like albinism, but that's why I'm sorry to talk about only albinism. But what I know somewhere, they were like they made like a alarmistic system in the different hospital. Like whenever we have a newborn with albinism, they have to contact the leader. So this leader will come and teach the mother and the family members of this newborn about the condition. So that will help those people to start taking care of this child when he's still young, because we have realized like people are developing skin cancer because they have been exposed since when they were born. They were not using the appropriate measure for protection. So it's very important to connect newly diagnosed patients with the one who are experienced, who have the one who know how to copy, so they can be able to help them. Role modeling and hope. Sharing personal story is the same, and promoting resilience. That will demonstrate that living well is possible even with a chronic skin condition. A collaboration with profession. It is very important to bridge gaps. So as a patient leader, you can act as a liaison between dermatologist, mental health provider, and patient, ensuring care feel respectful and culturally appropriate. And always also gather patient feedback on services and help shape program to be more responsive to psychological needs. In practice, what are we supposed to do? This is a summary. As a patient leader, you have to run a monthly peer support cycle for persons with skin condition. You have to offer short mental health check-in during a dermatological outreach. So when you go, you organize your outreach, don't just be focused. That don't just when you are budgeting things, don't just budget for skin condition. Know that in each outreach you are organizing, a mental health practitioner has to be involved. So it can screen for mental condition, this common one among your patients. Always put the mental condition or mental health in the package. Always. You have to develop culturally appropriate leaflets on self-esteem, stress management, and where to find help. And you have to act as a spokesperson to local authority to improve mental health finding in dermatology service. So this is the take-home message. That we have to know that mental health issues are common among dermatological patients. So screening for this common mental condition like depression, anxiety, social distress during dermatological visits, and having a referral pathway to mental health professionals can improve the outcome for both skin and mental health. Thank you very much. I'll try as much as possible to summarize, and I'm available for any question and clarification if it's needed. Thank you very much for your attention. Matondo mingi, asanteni.
Thank you very much, Dr. Ray. We truly appreciate. We honestly don't deserve you because you've given us everything. We'll take quick questions. So whoever has a question can just put their hand up.
Rachel, I see that yes. Mohammed has raised his hand first.
Okay. Kindly unmute Mohammed and go on.
Thank you so much. Dr. Inena Wa Inena is also my lecturer at KIU International University. Actually, it was very interesting topic, mental health and skin condition. I have two questions, doctor. Actually, we talk about the many things about biological, psychological, and social condition of skin condition, whether albino or erythema. So, what is the role can family and peer groups and community support play in reducing psychosocial stress among people who have skin disorder, whether albino? My second question, how community awareness program help to reduce discrimination and improve well-being of those individuals who have a chronic skin disease, whether albino? Thank you so much. I submit.
Thank you. Doc, you can take that as we proceed.
I don't know. Can you please summarize the question? I didn't get it. I'm sorry. I didn't get it.
Yes, doctor, I can summarize. The first question, how can a family member or peer group and community support team can reduce those people who have psychological stress of skin disorder. So how can our community and family member can support those people who have suffered albino? Yes, because since they face about many challenges of stigma. Thank you so much, doctor.
Okay. Thank you, Dr. Muse, for your question. You know, the most important thing is about the knowledge. The family members has to be knowledgeable about that condition. Like they have to know this condition very, very important. So if they know, as we say in psychiatry, what to do psychoeducation about that condition. When they are well psychoeducated, they know what is the condition, how someone gets this condition, what are the symptoms, what are the complications, how you can manage the things, what is the prognosis. So these people can handle very well when they know those things very well. I think the first things to do, they can support this patient by getting the knowledge. First of all, they have to get the knowledge. From the knowledge, they can do everything. I think this is the core a core answer. Very important to know first the condition, to have the psychoeducation about the condition. So from there, they can do everything.
Thank you. Tom Radido. Tom Radido.
Oh, okay, thanks. Yeah, so thanks, Dr. Inena. I think it's quite a lot of information that probably most of us have seen in some places, but you've managed to sort of consolidate it in a way that I think most patient leaders are able to understand. But I think for me, it's more or less like because I'm looking at it in terms of the current progression around skin issues. So we had the World Health Assembly resolution on skin diseases. So that was one. So of course, that was one major one that can offer breakthrough, because a lot of this information, they are always there. It's only that there's never like somebody to push anything. Probably maybe the reason behind that has been because we don't have an existing standard specifically for skin issues. So probably my question is, because I know you cut across dermatology and psychiatry, and there's a lot of mental health aspects that I think you bring into all that in terms of getting us informed on how, as patient leaders, we can sort of lead. But do you think whatever information around skin and mental health, are we able to have a standard indicator for mental health? Because I know in Kenya we have something called, and I think it's there everywhere else. So there's diversity, equality, and inclusion, which has indices in terms of a measure. So an institution, they'll go into an institution and then they say, okay, fine. In this measure, where are you in terms of the level of measure? So for skin issues, and in terms of just trying to push the issues to do it broadly, just skin equity in terms of a focus into, if somebody has eczema, they have services tailor-made to persons with eczema. If somebody has albinism, like right now, I think at least for albinism we have sunscreen that now is being recommended as a treatment option for persons who have albinism. And then like that. So is it possible to just within the mental health sphere to have an indicator that can be used as a measure, standard measure, so that even for patient leaders, we are able to know how much we're doing in terms of advocacy? Because I think one of the issues that you mentioned was advocacy, and advocacy is one of the pointers that we can use to try do a reduction in terms of all those issues that affect people who have skin issues. So is it possible to have a standard measure for mental health that affects skin? The other question probably could be maybe for Tony or Global Skin. So because I know Global Skin do PRID. PRID has quite a lot in terms of information that they collect broadly across the continents on organizations and skin issues. Whether probably maybe Global Skin can also maybe jump in to use that to try assist now the patient leaders to be able to socialize the impact of mental health on skin, because it's actually broad. It's actually a broad information that covers some aspects of mental skin as well, mental health in skin, so that now I think patient leaders can be able to probably just pick that information and see how to use it best, because they interact so much with the patients down there. Yeah, so those are the two questions. that I had. I know it seems like it's taken a lot of explanation, but I know Inena, you're up to the task anyway.
Yes. Thank you very much. I think Rachel, do you allow me to answer?
Yes, please go ahead. Go ahead and answer.
Yes. You know, we have this emerging field called psychodermatology. Is a new field. Yes. So before, people, dermatology was this side and the psychology was the other side. And it's just now that we are trying to bring this new field called psychodermatology that can link the two. That is one. Secondly, we have some standard measure which has been organized in the form of some tools. Like I can give an example of DLQI, like dermatological DLQI, quality of life index, something like that. So we have some standard measure for different stuff. So we have the one standard measure for general mental condition, dermatological condition, and we have some standard measure for particular one, like for eczema, for what, but they are not for all of them. I can say, like, we don't have, like, I can give an example, like for albinism, we don't have the standard measure to measure albinism, like mental health among persons living with albinism, the particular one, the specific one, no. So if we want to measure mental health, maybe on this particular condition, we have to use the general one. So as we are using the general one, we can be biased with, you know, what they call sensitivity, specificity. So those standard measures are more sensitive than being specific. So that's why we are still working on that. I think one of what I'm doing, my PhD, I'm putting a standard measure to assess the quality of life of a person with albinism. That will be very specific for that. So in conclusion, standard measures are there, but they are more general and they are not concerning all like other like different diseases in a particular way. So this is what I can say. And we are still working on that. As I told you, this is a new field, and we are still doing something like that, and that can help us in the future. Thank you.
Okay, thanks. Yeah. So I've seen Tony has shared something, but probably before Tony jumps in. So do you think, because the dermatological quality of life index, it's been used for quite some time right now. I think it's probably been the only one. I don't know, unless maybe there could be some others that are there in the market. But if from your assessment of PRID measure, can it best describe, comprehensively what we can handle around skin that the dermatological quality of life index measure is not able to measure? Because I know it's been there. Maybe they've not improved it. Of course, I know that always those standard measures that they stay for a long time without any sort of improvement, and then you find maybe some new inventions that comes in that at least sort of try to comprehensively cover quite a number of indicators that are not covered traditionally. So that now if PRID is good, then now you rally us towards PRID, so that because if the quality of life index measure is limited in terms of how much impact it can give to skin patient broadly, not necessarily just in the aspect of mental health only, then we literally just go PRID, because it covers literally every other region across the globe. Maybe the quality of life index measure was maybe an item that was being studied in the university, and maybe a small data set was collected at that time, and then it was adopted because there wasn't any other one. But right now we also have PRID. If you probably could also look at PRID and see, and then advise us so that we run towards one that handles everything, so that we don't have two life skin index measures, that one covers the other one, that they all at the same time exist, and yet we can only just rely on one, and I think we can just now develop that other one and then advance and then move ahead.
Thank you very much for your input. I think in this field is a matter of being more specific and sensitive, and that is calling for research to be done like in the field. As I'm giving you an example of many conditions that we cannot assess them in a specific way, because the patient who is experiencing, for example, eczema, the burden of eczema is not the burden of vitiligo, for example. It's not the burden like the person with psoriasis is experiencing. So they are different. So it's very important to consider something which is more specific than something which is taking broadly the condition. So that is an appeal for all of us, maybe, to think about everyone in is field to think about carrying out research and bringing something which is things which are more specific than sensitive and broadly covering many conditions.
Thank you, Dr. Just to remind us that please let us try to be as to summarize as possible, so that even the doctor can keep track. Mr. Way, someone's called Mr. Way. Oh, it's Mr. Y. I'm sorry, I can't pronounce it well.
Yes.
You can go ahead.
I'm an iterant. It's Mr. Way. I'm always on the way.
All right.
Yes. All right. I'm curious regarding the sunscreen issue. That in my country, I can see that they are utilizing benzene and alcohol upon the product that they are providing for our skin. So I want to check with the doctor, as he's so fast with the information. Is that suitable, or we must maybe advise on the cosmetics matters when they produce the products for us? I think it 2 years back or 4 years back, there was a challenge with the benzene from the Johnson & Johnson to say it's the one that is causing cancer. And it was withdrawn from our country, from the shelf. So now that they are providing product that has got the benzene and alcohol, I'm still skeptical to say, do we advise upon that, or is it suitable for the skin? Thank you.
Thank you very much for that question. I don't know, from which country, please?
This is Mr. Way, your friend from South Africa, Mr. Gaylord.
Okay. Yes, I'll try to speak about evidence-based way of doing things, of treating things. Yes, Mr. Way, thank you very much. So, is there any evidence like linked to what they are suggesting to people to use? And the good news for sunscreen, do you know, the WHO has just accepted to consider to include sunscreen like essential in the list of essential medicine. So in our different countries, now our countries, like our government, can buy sunscreen easily, can include it in what. So the accessibility of sunscreen for people who need it will be very important, very nice, because of now it is included. And no need of using what you are talking about. I don't have any information about that. Maybe I will try to read through. You sent me what you are talking about. I will read through and maybe come back with the answer in the group, in the WhatsApp group. But I don't have any information about that. And the good news is that sunscreen now is included in the essential list of medicine.
Thank you, Mr. Wei. I don't know whether there's another hand up, but I'll just also take my question, Dr. Gaylord. I would like to know how, from your experience as a patient advocate as well, as a doctor, as a practitioner, and also as a mental health practitioner, wellness. How do you, when you go to the remote villages, how do you, mental health is not something that is really accepted. We don't come from a space where, especially Africans, they accept talking to other people, sharing their issues with other people. So, and I'm looking at a remote village, assuming a remote village in Uganda or now in Kenya, but from experience, I'll give Uganda or Congo. How do you approach this conversation respectfully? Like you said, you have to respectfully put your package, your work. Thank you.
Thanks, Rachel. So before Dr. Inena comes through, so in addition to patient leaders, this webinar also has a cohort of patients that have actually joined in. And perhaps we could accommodate a couple of them to ask very specific questions of their experiences, if at all we have any. So perhaps we could just ask around if the patients who are not patient leaders who have joined in and would want to speak about their experiences and perhaps precede their questions ahead of everyone else.
Okay, Doc, you can still go ahead with the question as we take that.
Okay. Yes, as I said, when we are organizing our outreaches, when we go to the community, it's better to include mental health among our activities. So what you do, first of all, you have to talk to the local leaders, like the political leaders. In Uganda, we have what they call the LC, the chairperson. So they are the one who are administrating maybe a certain portion of what. First of all, you go, you talk to them about a condition. You talk to them. So you psychoeducate. I was emphasizing about psychoeducation. You first talk to them about the problems. You talk to them about the burden. You talk to them about like especially the burden. Like if you have these people with this condition here and maybe they continue to be like that without assistance, you see your community will have face problems, biological problems, psychological problem, and this one. You first address, you talk to them, you tell them, you make them to understand about the condition, you psychoeducate them. Is from them to organize with you now those sessions. So for him, he knows very well what are his problem, what are the common problems that they have the place, and how you can maybe tackle them. He knows all his people, the way they are, the cultural behavior which is accepted or not in this community. Because something like mental symptoms, you consider them like mental symptoms when they are not culturally accepted. You see, we have in certain community where drinking like alcohol is okay. And in others, drinking is not acceptable. So you can't go in that side when you know that alcohol, maybe substance abuse is bad for you, your knowledge, and you go the other side, you want to show them that it's bad, yet in their community is acceptable. So we define mental condition when a certain behavior, a certain perception, a certain, I can say, behavior, perception, or a certain thought is causing impairment in the functionality of the people. So as long as people are okay with those things, in that their community is very okay for them. So that's why it's very important to first to tackle what for us we do. We first go and we talk to the leader. And this leader will tell you about this community. So from there, you can know the people you are talking to, you are dealing with them, what are their common problem, what you consider like is problem, maybe for them is not a problem. So you see how you can say rearrange your talk or your intervention. So mostly you start by there, and it's from there that you can determine how to tackle your intervention or to tackle your problem according to what you see you get from these people. And also they are the one to allow you to do everything. You can't just go and enter in a certain community and start maybe doing your intervention. You can even face the problem with the law and the political things issues. This is for us what we do. This is my experience. I know, as is Warren said, that everyone has experience. For us, this is what we do. Thank you.
Thank you so much, Dr. I don't know who is giving the experience. Melvina?
Rachel, sorry if I can just interrupt just to
Yes.
talk about the order. There are two questions in the chat that I definitely don't want to get lost. Florence has raised her hand as a patient, and I think she's keen to offer some perspective. And then hopefully we can go to the two questions in the chat for Dr. Gaylord, and then we can go to Malvina, if that's okay. Florence, you're welcome to turn your mic on and share with us.
Good evening, everyone. My name is Florence. I'm from Zambia, and I've got neurofibromatosis. I got it from my mom has it, and we're 8 in our family. Then 2 of my siblings have, so 3 of us has it. Then the others don't have it. And the challenges that I've been having is that a lot of people don't know about it, especially in my country, Zambia. So you find that everywhere you go, people will be looking at you, and that has led me to have low self-esteem. Ever since I was a child, I knew that I was going to have it because this is when I'm having physical symptoms. Earlier, I never used to have them, but it has really affected my self-esteem, and I can't operate in open places like that.
Doc, you can take that.
Yes, Florence Mwale, thank you for your question. I don't know, in your country, do you have like some, can say a peer group, like some group of people experiencing the same condition that you have? Or any like dermatological organization that's like?
Yes, there is a group that I recently joined. It's there. Yes, I recently joined. I'm not really active, but I recently joined.
I think one of the way of coping with a condition is, first of all, knowing it. This is what we are emphasizing about the knowledge. Having the knowledge on the condition. Understanding that everyone in this world has his problem. in psychiatry we have something we call positive thoughts versus negative thoughts. A negative thought is when you think like everything has to be okay. Everything has to be in line with what you want, what you think. This is a negative thought, like thinking like maybe you will succeed in whatever you are doing is a negative thought. Thinking like maybe you will not die is a negative thought. So we have to know that anything can happen in this life. When you put it in your mind and you know that everyone has this problem, this is your problem, and you have to cope to know how to cope with this problem. That will be very important. And when we have talked about peer discussion, like that's why I'm recommending you to be like attending this group, being active on that, sharing knowledge with others, sharing experience, and having positive thoughts on whatever you feel you face in your life. That will see it can help you to cope. So put in your mind like everyone has his own problems. Me as a doctor, I'm telling you, I'm a psychiatrist, dermatologist, but I have also my own problems. My own problem that I cannot, sometimes it's a burden for me. But the way I tackle them is by, we call it mentalizing those things, like understanding that this is my problems. I have to think about in a positive way, and I have to live with it. I have to know it very well to know how to tackle it. So that is it. So please, we are available. Maybe after this explanation or this webinar, we are available. You can still call us and we can advise you. We can connect you with other people there maybe, and see how we can help you to reach this level of resilience, of understanding that this is something which is going, this is my condition, this is my burden, and I have to live with it.
Thank you, Doc. That was, she's from Florence, you're from Zambia. Probably you can last with Warren. Then Warren will see how to connect you to other support groups within your jurisdiction. Tony, we can take another question.
Yes, sure, Rachel. I think while we're having patients share, I see that Malvina has sent a message in the chat. Malvina, would you like to turn your mic on so that we can hear from Anthony from Liberia? Sorry, we can't hear you yet. It still shows that your mic is off.
Anthony, you're able to hear us. You can unmute. Melvina, you can help with that.
Can you hear now?
There we go. We can hear you.
Okay, Anthony. Okay, I'm Anthony from Liberia. As for my own experience in this problem, I suffer a lot, which even we went to other hospital, they said no cure, only to cut my legs, and which it worried me a lot. But alas, when I met NTDS, they the one now gave me hope, and with the treatment, they're doing all right for now. So for that, I really appreciate them. But the only thing is the medication to carry on is very hard. They just give it to all there, you take it in right away. So that's my concern. But I thank you all so much.
Thank you, Anthony, for sharing. Doc, you can take
Okay.
that. Or Melvina, you also wanted to share together?
Yes, I just want to say thank you for this opportunity to be a part of this meeting. I want to say thank you and bless God that will continue. You people will continue to support NIPA entity Liberia. I want to say thank you so much for your care.
Thank you, Melvina. Desiree, you can take Anthony's concerns.
Rachel, I didn't get his concerns very well. I don't know. If can you help me to repeat? Maybe. Sorry.
Yeah.
Okay.
Melvina, are you able to break down? Yes.
Yes, what Anthony was trying to say is that he's very grateful to the group, which is NIPA Entity Liberia, for supporting him because he has been through a lot, through his experience with a big fault. He have a lot of stigma. People never used to come around him. He went to the native doctor. They were doing his foot stimulate, doing other country traditional medicine. So for now, he started going to the hospital, and he's grateful that he's doing well now, that people can come around him, no more stigma. So he's happy, he's grateful to be a part of this group. That's what you're trying to say.
Mm-hmm. So if I understand very well, Anthony was sharing his experience, and this is a very grateful experience.
Yeah. Yes, thank you very much, Melvina and Anthony. We truly appreciate you, and we're happy that you've beaten stigma. That is amazing, and that's a powerful story. Thank you for the courage to share your story. Emmanuel, we are running out of time, kindly. Emmanuel Zaide.
Yes, so thank you for the privilege and this one of our member. So just what the doctor said, the peer lead, the peer support group is very important in reducing stigma because if a group of persons affected group themselves together, then definitely the community or other persons who think these conditions can be treated, they will see their friends in group and go in one direction. But just to quickly say that sometimes there can be several challenges with peer groups, with peer leaders or patient leaders, because sometimes if the national ministry does not recognize you or it is not pushing your agenda, so sometimes to be successful it can be difficult. So what way if the national is not supporting your advocacy channel, in what way can you manage to sustain your activities that you want to do because you are giving testimony and you want for others to follow your full steps? So those are challenges that we can really have, especially when the ministry is not looking up to you and you don't have funding to carry on your activities. So sometimes it kills the dream of the patient leaders. So those are things that can hinder the activities of the peer group. So for us in Liberia, we have a peer support group, and we had a project that came to assist, and then they were leaving, so we decided to maintain their legacy. Their legacy was they came with the idea of establishing peer support group in their interventions counties. So as they were leaving, we lobbied with them. They were able to register us as an organization. So we also talked to them that we could continue the same activities of the peer support group. So for sure, the peer group is very important. It is another way of reducing stigma in a community. So those are just challenges. How can the peer group survive, or how can the peer patient leaders survive without being supported by the National Ministry of Health in the countries where they are? It's over. Thank you.
Thank you, Doc. I don't know whether you understood the question well. I can see Tony has posted it in the group. Basically, Zaize Emmanuel is asking, how do patient leaders engage with these activities when you aren't supported by national ministries? Doc, you're there? Doc? Oh, he had left a bit. I think he's come back. Doc, are you there? Warren, you can
Yes.
probably intervene as Doc comes back. Okay.
Sorry, Rachel. I think he's just rejoining.
Okay.
Yes,
Good
Rachel.
evening.
Yes. Yes, Doc, welcome back.
Okay, I got problem with connection network here. Sorry.
Yeah. Tony, you are able to read for us the question?
Sure. Dr. Gaylord, we just have 2 questions from the chat. Emmanuel has just spoken, and the question that he submitted in the chat was, how do patient leaders engage with these types of activities when you aren't supported by national ministries?
Rachel, excuse me, can you repeat that Tony question?
Okay.
No problem.
Okay, generally, basically, Emmanuel is asking, Tony, I can take that, is asking how can patient leaders engage with activities when you're not supported by your national ministries?
Okay. Thank you very much for the question. I think being a patient leader is a vocation. Is a vocation. You have been called is something that you are doing it because you have been called by yourself. You don't need to be supported by the government so you can engage on these things. Sometimes the government, they want to see from you as a patient leader, something that's you are someone who is dedicated to what you are doing. Because we have many people who are doing this work, but because of maybe they are looking for some interest or something like that, or they are not doing it because of they being called. Me, I'm sharing my example. I'm not supported by my government. I have started to do these things alone because I saw in my community person living with albinism dying for skin cancer. And I was asking myself, can this thing can be preventable? And I've tried to learn about, and I realized that those things, before to become big, they start by a small lesion that we can just remove. And you can remove it easily, and the person gets cured. And I've started to do it alone without any support. Is after you working and your work, the work of your result of your work, that people will understand, like, now this one is doing these things in a good way, in a good mood. He's not doing it for something else. So you will see support will come even without you asking. So I think as a patient leader, please work as someone who have been called, like someone who is doing it from your heart. So the support will come. Just do that. I'm a Christian. I believe in God. I know God cannot leave you when he sees your heart is good. He will send people to say, even if it's not the government, other people will come. We have many people who are looking to support people who are doing great job. So this is from my experience. I think like we don't have to wait for the government to support us. You will reach a certain level where this government will come to look for you. First, do something from you, from yourself, from your means, and everything will be possible. This is from my experience. Thank you.
Thank you, Doc. The other question, I don't know if it's the last one, Tony. It says, Doc, from a policy point of view, what would you advise we should focus on in terms of advocacy, especially on what you presented on today? This is from Gaylord Inena. I'm sorry if I'm pronouncing wrongly.
I think, first of all, I don't know. The question is about what do you have to focus on in terms of advocacy. Is it that the question, if I understood it very well?
Yes, yes. Mm.
First of all, as a patient leader, I'm insisting about being called. I'm insisting about knowledge on the condition that you are dealing on. You have to know the condition. You have to know the condition. If you know it very well, you know how people get the condition. What are the symptoms? What are the complications? How can you manage the condition? All these things, first of all, if you know it, you will know where to tackle. That is one. Secondly, I think my last part I have been explaining you as a leader. What is your role? I think we have to focus after having the knowledge, you have to focus on the other 10 points, important key points that you as a political leader, you have to know. So you have to practice. That can allow you to fight against stigma among your patients and to help them to cope with their mental challenges. Knowledge and the 10 key points, the last one. Thank you. Submit.
Thank you, Doc. Tony, I don't know how much time we have.
Yes, we are slightly over time. We just have, if anyone would like to stay on to for the last two questions, and then Fikre would just like to say something at the end. But yeah, if anyone has extra questions for Dr. Gaylord, you're welcome to pop him an email. We did have someone, Sydney, if you want to turn your mic on to ask your question. Otherwise, you're also welcome to email Dr. Gaylord. It's up to you. And then there was also someone with your same name, Gaylord. So perhaps you shared your login link. Oh, I see he's just written in the chat. Go ahead, Sydney.
Yes, this is Sidin from Zambia presenting PCI. Actually, me is just a contribution or just adding to what Dr. Has represented. It is wonderful representation. And I wanted to talk about mental health. The challenge is stigma. We have these, patients here in Zambia, which are actually isolated with, vitiligo, asthma, and other diseases. So, what we have done is, according to a doctor, as he was presenting, this is mostly actually things that are actually are happening, is to provide them skills because they cannot be accepted in the community because of, diseases related. For example, vitiligo, asthma, and a lot of actually skin disease. So what I'm trying to say is it's very important that we need to provide this intervention by actually motivate these patients by providing support, social support, and also financial empowerment. I think that is a contribution that I wanted to submit. Thank you.
Thank you, Sydney. Tony?
Rachel, that is all that we have. I've just sent a little message to Tom.
Okay. I just want to thank all of you. Oh, why
before you do,
sorry?
Rachel,
Yes, Warren.
before you
Go
do,
ahead.
so we had a very beautiful turnout, and perhaps we could just have a group photo in honor of the beautiful webinar presentation. So if possible, people could open their
videos on.
they could open their cameras and see if we could just get the smiles.
Warren, I had Tony say Tom, so probably
No,
just had
Tom, you have to email. You have to email Dr. Gaylord. Sorry.
Okay, fine.
So,
I think it was just one
yes.
follow-up
Tony
question,
also,
but it's okay.
Tom, also turn
it's
your
okay.
mic or your camera on.
Let's do the photo
Tom,
first.
I'm putting you on the spot.
I'll try with my phone, but my other camera has an issue. Let me see how it goes, but it's okay.
Okay, great. I see that we have a number of cameras on. I'll just give it one more tick before I take the group photo. Odette, we have a green screen for you. We can't see you yet. Okay, I'll do 2 photos just to see which one is the best in the end and who's all got their eyes open. So I'll count to 3. So give us your biggest teeth smile. 1, 2, 3. Great stuff. And then I'll just do one more just in case some were blinking. And this one you can do thumbs up, you can do a Warren style, you can do a funny face, whatever you like. 3, 2, 1. Great. Thank you. Thank you.
Thank you. Thank you so much. Fikre, are you there? Fikre? Fikre is not there. Why don't you want to give the vote of thanks to Dr. Inena and the entire group?
Dr. Inena, this has been a very beautiful presentation. We enjoyed ourselves. I think as patient leaders, as well as patients that just joined in that are not leaders of organizations, I think it has been thrilling. I think we should perhaps have a webinar again to follow up. We've got pending questions from Tom, and I'm sure others too equally had experiences to share. I also want to thank patients that came through to give their experiences of living with a skin condition and how this affects mental health. Please do know that we have organizations within countries that are able to provide peer support. So reach out, engage, and try to remain as positive. I think on a broader end, we did speak about policy issues, and this is what we're trying to drive on an African initiative as an African network to see if we could have common themes that we could push for agendas across the African continent. And like what has been shared, have policies that could influence access to medicines like the essential medicines list with what has happened to albinism. So this is a great initiative, and thanks everyone for joining in. This is super late, but we're still very appreciative of the time that you've taken and looking forward for additional participation. If you do engage, I think we could also have an additional webinar exclusively discussing mental health again. So thank you everyone for coming through, and thank you, Rachel, for hosting us.
Thank you very much. It's a good night and bye-bye till we meet again.
Bye-bye.